Zach made some excellent points, and I wanted to sit back there and clap at a few things and amen in here and there, because we are in a very tough time as respiratory therapists, not only in the hospital but outside of the hospital. Just so I kind of have an idea of who's in the room, how many of you, raise your hand if you work in inpatient care? Okay, maybe half. The rest of you, outpatient? Ambulatory, home care? Yeah? Okay. So my talk today is primarily going to be related to a study that we recently did at Vanderbilt and was published within the last year in the Journal of Respiratory and Critical Care Medicine, the Blue Journal, called the PROPER trial. And it's Protocolized Post-Extubation Respiratory Support. Other than the funding for the trial, which Vanderbilt gets tons of grants from the NIH, we do lots of fantastic research on campus. But I have no disclosures other than I am not an entertainer, so don't expect a whole lot from me today, unless I have maybe some liquid encouragement at a karaoke bar. But that's a whole other story. So things I hope to accomplish, we're going to just identify the problem of reintubation within our ICUs. We're going to review strategies currently for using non-invasive and high-flow nasal cannula in the peri-extubation period. We'll look at some prior data related to preventative, non-invasive, and high-flow cannula use, and then we'll get into the results of our PROPER trial. So, as you guys, most of you guys know, respiratory failure is relatively common after extubation. About 25% of our patients that just go through our Vanderbilt Medical ICU are intubated at least once during their stay. And about 1 in 7, or 15% of those patients, require reintubation. It may not seem like a lot, but when we get into the data later, you'll see that we, on average, have approximately 85 patients that come through our MICU on mechanical ventilators each month. So the percentages for us will look a lot different for community hospitals. We also know that reintubation is independently associated with pneumonia and even an increased risk of mortality. So there's lots of data out there showing that subsequent reintubation and respiratory failures after initial intubations there's an increased risk of death. Really, the only two preventative type therapies that we have right now are high-flow nasal cannula and non-invasive ventilation, or BiPAP, interchangeable terms there. In the picture here, and what we used in our study was the OptiFlow nasal cannula interface from Fisher-Paykel, but the data around this would be very similar regardless of what equipment we use. So there's Vapotherm out on the market. I know Flexicare has a system. Hudson also has a system. So really, when I say high-flow nasal cannula and related to this study, I'm referring to a heated high-flow device, a heated high-flow therapy device. And I'm getting messages on my screen. You're interrupting me, man.
Recording in progress.
Oh, there we go. Recording in progress. We're a little bit late, but that's okay. So I'm not here to argue whether OptiFlow is better than Vapotherm. I can only share what we use at our facility and the successes we've had with it. There we go. All right, so here you see a traditional spectrum of the weaning process. So we have a precipitating event that leads to intubation. Once that resolves, you get to an area where we might consider a facilitative extubation. What I mean by that is maybe a patient has failed a SAT or SBT, their spontaneous breathing trials, but otherwise the patients look fine. There's a lot of data around our COPD population that says some of these patients just deserve a chance to fly. Many of you may be familiar with those patients. You can probably think of a few where their respiratory mechanics were probably not stellar, moderate, marginal at best, but they were looking at you and they were giving you the thumbs up, telling you they're okay, but their respiratory mechanics by measurement, by our historical or more traditional measurement, were just not good. But we want to give them a shot. So we have this certain group of patients that we might use non-invasive as an alternative to invasive ventilation. As you move down the spectrum, we have a group of patients who have gone through a successful SAT, SBT, and we extubate them, but maybe they're sort of in that marginal category, so they don't look fantastic, but they don't look bad. They pass their spontaneous breathing trials, but they may be at may have some risk factors involved that we want to consider using a preventative, either non-invasive or high-flow cannula. We have other patients who we extubate. They have great pulmonary mechanics, look good, feel good, sitting up in bed, and then for whatever reason, maybe they have an additional comorbidity or a risk factor or two, and they end up in acute respiratory failure. So we might use, in that scenario, therapeutic BiPAP or therapeutic, what we consider therapeutic high-flow nasal cannula. So we're going to take a look at each of these to see kind of what the data shows in here. I will note some of the earlier studies related to the successes with some COPD patients in using using facilitated non-invasive, basically as an alternative to invasive ventilation. They were very small, so the one noted on the screen here to the left, you can see the time and day factor across the bottom. I expect all you people in the back to be able to read that. But it was a very small group, but there was quite a bit of statistical difference in the group. It also should be noted that a lot of these smaller studies were done prior to normal SAT, SBT era, like we do now. I would guess that in most of your inpatient facilities, you probably have some kind of protocol or process that daily there are spontaneous awakening trials and spontaneous breathing trials. Seems to be pretty common now. Some more recent data related to using non-invasive in a facilitative process came out just a few years ago from the BREATHE trial in JAMA. It was a larger study that looked at over 300 patients, and it actually showed no statistical difference in the time to liberation from ventilation or mortality. So the more recent data suggests that it's not really helpful to use non-invasive as a facilitative method, but it's also not really harmful. So a little bit of limited data, or lacking data rather, around that. So we have some support that shows facilitated use of a non-invasive fails to prevent those reintubations because the two different arms on each of those studies showed that there was no statistical difference in the rate of reintubations. So now let's look at the therapeutic or the rescue non-invasive and high-flow use. So this is utilized when we successfully go through an SAT, SBT process, and we extubate the patients, and they look good, at least initially, but again, at some point they decompensate and start to fail. This study out of the New England Journal of Medicine from Esteban actually showed an increased length of time to reintubation as well as an increased mortality for those patients. So there is a little bit of concern there that maybe using it as rescue therapy is not quite as helpful as a lot of us, including me, thought it once was. Show of hands in here, how many of you guys have those patients who you extubate in the ICU and they get to a point of respiratory failure and you go and grab the BiPAP? A few hands. Anybody using high flow nasal cannulas? Yeah, so a lot of us are doing that, but now there's actual data that shows it may not be as helpful. But I will be the first to admit that I thought it would be helpful. I expected it to be helpful. It seems like in theory those things would be helpful, but when we look at the actual controlled data, it shows that there may not be as much benefit as we once thought. So what about this preventative phase? So using non-invasive or high-flow nasal cannula as a bridge. So we extubate, we go through a successful SBT process, and we determine that the patient is good to extubate, and we extubate them either to non-invasive or to high-flow cannula. Anybody out there doing that? Not as many. Okay, here's the point in the presentation where everybody falls asleep. Some of the data around using it as preventative in the post-extubation phase shows that there may be some benefit for a certain subset of patients, and specifically it's those with known hypercapnia on SBT. This study out of critical care medicine from NAVA showed a 75% reduction with 48 hours use of non-invasive. Now, 48 hours use, 2 full days of non-invasive use can also cause some problems on the downslope or downstream of that placement. I don't know if any of you have or are experiencing this now. We're seeing some concerns in our facility related to pressure injuries. So you think of the traditional BiPAP mask that sit over the bridge of the nose right there. It's starting to cause some significant concerns in our facility. A lot of it related to our COVID or post-COVID population, just because of their poor nutrition status. They've been in the hospital for a long time. Skin is starting to break down. They're losing a lot of their natural barriers to these things. But nevertheless, it is a concern, a significant concern. There was some data released out of JAMA from Hernandez that compared high-flow cannula to non-invasive ventilation. So cannulas to, heated high-flow cannulas to BiPAPs. And a couple of different groups that Hernandez looked at. One was high-risk, what they considered high-risk non-hypercapnic patients. And then they had another group subsequent to that publication, just right after it actually, that looked at low-risk non-hypercapnic patients. And the results of those studies actually showed that the heated high-flow cannulas were non-inferior in these populations to non-invasive use. So that would lead to the question or the consideration of using a heated high-flow cannula versus a BiPAP mask. So thinking of some of those downstream unfortunate things that happen, like pressure injuries, could the use of heated high-flow cannulas in some of those scenarios prevent that risk of pressure injuries? But a lot of those studies that I previously mentioned led to several national groups releasing guidelines to say that for high-risk patients, intubated for greater than 24 hours, you should be using non-invasive as a preventative measure when you extubate those patients. Now, of note, you won't find anywhere in those publications a true definition of high risk. So I think that's a problem across the board that nobody can really agree on as to what is high risk, what makes a patient at high risk. So even though we have these guidelines out there, there's not a clear definition of that. So to take a quick look at the summary of the post-extubation or preventative support that we have. For hypercapnic patients, this subset, there is data that shows clearly that non-invasive decreases mortality and it decreases your rate of reintubation. There's quite a bit of supportive data on that. Then we have our non-hypercapnic high-risk patients, although not clearly defined. There is some suggestion that non-invasive decreases reintubation, but also that high flow cannula is not inferior to non-invasive. So if you have a BiPAP device, set it up. If you have a heated high flow cannula device, set that up. They're going to work about the same. Additionally, there's the non-hypercapnic low-risk patients that also shows the same thing as your non-hypercapnic high-risk patients. So that begs the question, should then everybody get something? And should they be delineated by hypercapnic or non-hypercapnic? Here's a quick summary of this, and something to consider with those studies is that if you notice the reintubation rate in the control arm, there's some thought that maybe these studies were cherry-picking patients to show the data that they wanted to show. And by the way, all data can be manipulated to show exactly what you want it to show. So just a word of caution when you're, yes, yeah, like that. Just a word of caution when you're reviewing a lot of this stuff, you always need to keep that in mind and look at how the study was set up and how the data is being presented. Sidebar, my apologies for that. What is the nationally accepted or agreed upon average rate of reintubation? Anyone know?
12%?
So about 10 to 15%, yeah. So if you look at the studies here, this reintubation rate in a control arm, it's anywhere from 19 to 24%. It's almost a quarter of their patients were getting reintubated. Even the Hernandez study that supposedly looked at the low-risk, non-hypercapnic patients, there was a 12% rate of reintubation, which is in that moderate range of expected. So were they truly low-risk patients? Even in our medical ICU, we have about an average of 12.5% reintubation rate. So that kind of set us up for asking the question, and really that's what research is there's a question and we do a formalized research process to figure out the answer to that question. That led to the proper trial, which is a prospective, unblinded, pragmatic trial. And it was set up that way so that it could just be, I have two of my practitioners sitting in the audience, and I want to say that it was, I guess, easily integrated into workflow, but y'all probably won't agree with that. Although in the design, that's what we had hoped, right, was that it could just be easily implemented into a normal workflow process. Now, with all research studies, if there's active decisions that have to be made, of course it's not going to be quite as easy as a normal workflow. But we thought we were relatively considerate, and we had several practitioners on the front end of this helping to design that protocol. So I'm very proud of what all of my team was able to accomplish in this. It was an 18-month study, ran from October 2017 through March 2019. And again, I said it was just recently published in the Blue Journal. Inclusion criteria was just every patient who was undergoing extubation in the Vanderbilt Medical ICU, except for cases of self-extubations where the patient needed immediate reintubation, as well as some deemed, reintubations deemed necessary by the clinical team. Exclusion criteria was anybody intubated less than 12 hours, do not intubate orders, and patients that have been previously extubated. So we didn't consider the data from those subsequent intubations within the same hospital stay. The way it was designed, we just split our medical ICU right down the middle. So the way our ICU is set up, it makes a big U, or I guess realistically it's probably a block A because there's a corridor in between. Either way, we have lots of rooms on the outside, and we have a couple of connectors coming through the middle, and we just split them right down the middle. So one half would get the protocolized care, and the other half would get what we would call usual care. And the groups would alternate every 3 months. So side A would get protocolized care for 3 months, while side B received usual care, and then each quarter we would swap those. I'm not sure I believe Zach when he said there would be no more technical difficulties. That's okay, we'll muddle through this, right? All right, so the protocolized support arm, all patients extubated to either non-invasive or high-flow nasal cannula. Those patients with suspected hypercapnia, or if we actually got a blood gas, which we didn't routinely get them during the SBT or SAT process, just suspected hypercapnia, or those who were intubated for a COPD exacerbation, they got BiPAP. All other patients would receive high-flow nasal cannula. We would assess for readiness to wean at 5 a.m. the next day, every day. So it was sort of lined up with our typical SAT, SBT process. And then all other aspects of care were just determined by the team. On the usual care side, it was business as usual. So the clinical care teams would decide how they wanted to treat the patient. I will say there was still a lot of high-flow cannula use on that side. There was some non-invasive use on that side as well, but there was no guidance from the clinical team. This is just a picture of kind of a flow chart that we used as the decision process. Probably a little bit hard to see. Some of the primary outcome we were looking for was reintubation within 96 hours of extubation. Other secondary outcomes that we were looking at were the number of ICU-free days in the 28 days following enrollment. Other exploratory data was all-cause in-hospital mortality, ventilator-free days, time to reintubation. What we didn't want to happen was to use non-invasive or heated high-flow cannula to a point where it would increase the ICU days. I don't know about your respective facilities, but every day we have max capacity. So there's this constant push to churn these patients, right? We always need ICU beds. We always need step-down beds. We always need acute care beds. We always need ED beds. Now we just need more home beds. Anybody working for a hospital-to-home program yet? Other than the cool stuff Zach is doing? No? So that's coming. That is actually being explored now, this hospital at home process. We actually just opened our own hospital at home unit at Vanderbilt. So quite interesting stuff coming out about really just the churn and efficiency inside the hospital to get patients outside of the hospital. All right, I'm going to have to squint to see this. You guys probably just see a couple of boxes and lines up there. But just so you know, we enrolled, I'm sorry, not specifically enrolled in the study, but we had over 1,500 invasive mechanical ventilation patients in our NICU during this study period. I mentioned earlier that works out to approximately 85 new patients each month that rotate through there. So relatively large volume. We ended up with almost 360 in the intention to treat side. I'm sorry, on the protocolized support side, and then we had 392 on the usual care side. So quite a few patients in this study. Here's some of the patient characteristics. So we believe we have a well-represented patient population because of the number of enrollees that we had. Median age was relatively the same at 56 and 57. So between the protocolized support and the usual care support arms, all the patients were pretty equally represented across both sides of that. Of note, a lot of the data that came out of this was, like I believe I mentioned it earlier, was driven by the use of high-flow nasal cannulas. So we have seen quite a bit of an uptick over the last 2 years in our just general use of heated high-flow cannulas. So you can see here on the protocolized support arm, it was about 75% related to high-flow cannula patients, and only about 3% on the usual care side. Non-invasive only represented about 17% for protocolized support and about 15% for the usual care. Now again, we didn't check ABGs to confirm hypercapnia on every patient for this, so it was just a suspected hypercapnic patient that we would use non-invasive on the protocolized support arm. Looking at our primary outcomes, so the reintubation within 96 hours, so that was really the driving factor behind this is, would a systematic approach to post-extubation management reduce reintubation? And if you look here, just looking at the reintubation within 96 hours, there's really no statistical difference. So it was almost like a game show failure music playing in your head. Wah, wah. I'm sorry, what you thought was going to be beneficial, the data really didn't show that it was beneficial. Secondarily, the ICU-free days were exactly the same. So it was actually a major letdown, especially for me. I don't know how all of our practitioners felt, but I talked to several of our provider team members who expected the same thing, right? We thought we were going to see a much lower reintubation rate on this protocolized support arm, but we really didn't see that. Here's a competing risk analysis that compares rates of reintubation with the protocolized support and the usual care support, as well as mortality. And you can see the top two lines trend exactly the same, and the bottom two lines trend exactly the same. So statistically, there's no difference, in our usual care and our protocolized care. So we got to thinking, is there any differentiation in these groups? So considering how the process was set up, remember I said the patients were evaluated at 5 a.m. the next morning. So if a patient got extubated at 3 a.m., they would only be included for about 2 hours of care.
Progress.
Yeah, I'm making progress. Give me just. So we pulled the data, or started digging into the data to say, if you received the support for a longer amount of time, would that make a difference? So again, whether you had 3 hours of support, or if you were extubated at 6 a.m., you had 23 hours of that support. And again, it didn't show any statistical difference between the two. So you can see I'm saying you can see like I know that all of you can see, but let me say it this way. On the slide, it shows a red line and a blue line that tracks pretty much the same across the duration of the intervention. So there's no statistical difference in the rate of reintubation based on the time of support received. What about the risk factors? When you break down the risk factors, either 0, 1, 2, or 3, again, there's no statistical difference between the two groups. So the dark line is the protocolized support arm, and the light gray line, at least on my screen, I don't know how your screen is set up, is the usual care. And you can see, other than that one risk factor, and again, that one single risk factor was not clearly identified, or there wasn't a consistent single risk factor associated with that. But that was the only area that showed even a minor bit of difference when you break down the data. What did come out, or where we saw a separation in the groups, was when the duration of mechanical ventilation was greater than 7 days. So you can see about that 7-day mark there, the two groups start to split. So on the usual care arm, there was a higher probability of reintubation compared with the protocolized support arm. Of note, some of the previous studies that I mentioned that showed some benefit, when you dig into their data, the average length of stay for a lot of their patients that were enrolled in those trials was around 7 days, whereas our ventilator length of stay during this study period was about 3 days. So the graph here shows that after that 7-day mark, the same as a lot of those previous studies showed, that's where you're could potentially see some benefit with utilizing non-invasive or high-flow cannula. Other exploratory outcomes, nothing really here clearly stood out again. Even among the indication for reintubations, everything statistically and percentage-wise was about the same for the protocolized and the usual care arms. I mentioned ventilator-free days earlier were exactly the same. Some of the strengths related to this study, because again, remember, all data can be manipulated. So some of our strong points were it was a cluster crossover design that enrolled a patient population that we felt was well represented just across the, I guess, nation or across all of the expected patients in our ICU. It gave us a well-represented population enrolled in the study. It was what we thought and what we had hoped would be highly pragmatic, so that the delivered intervention was just easily integrated into regular care. It was the largest enrollment trial at the time for post-extubation respiratory support. So we did get a lot of patients. We felt like we had really strong data in that. Some of the admitted limitations were that it was only conducted in our Vanderbilt MICU. It should also be noted that this was for primary respiratory failure patients. So this was not considering a lot of your post-surgical patients or a lot of patients that were admitted for procedures, so short durations of stay, no pulmonary issues involved, those very easy intubated and extubated patients. So this data, remember, is just limited to medical patients, specifically respiratory failure. Again, we didn't get routine blood gases to determine hypercapnia. In the trial intervention, the protocolized support arm included both non-invasive and high-flow nasal cannula, but a lot of the data was largely driven by high-flow nasal cannula use. In summary, to cover what we've been through here, we know the application of non-invasive following extubation for hypercapnic patients has been shown to reduce morbidity and reintubation rates. We also know the application of both non-invasive and high-flow nasal cannula at the time of extubation has been proposed for a lot of patients, a broad spectrum of patients who are non-hypercapnic, both high risk and low risk, however you want to define that. And in our trial, the protocolized support failed to prevent reintubation as we had hoped and as we had expected among the broader population. We also learned that it was not affected by the duration of support, and it was not more effective in those perceived to be at high risk. So the one little nugget that we pulled out of this was it did show some success in those patients who were intubated and ventilated for greater than 7 days. That's just a recap of the previous one. All right. Wake up time. Let's see. How early am I? I promised Colleen earlier that I would get them back on track today. So